J'ai le grand plaisir pour clore finalement ce formidable symposium, je m'appelle Philippe Sansonetti, de présenter le prix Lacassagne 2020 au docteur Simon Cauchemez. Je pense qu'il ne va pas tarder à apparaître sur l'écran. Ce prix est décerné par le département de biologie du Collège de France à un scientifique, une scientifique qui a fait un travail tout à fait notable sur le plan de l'originalité et de la qualité. Je vais vous présenter rapidement Simon Cauchemez. Simon Cauchemez est directeur de l'unité de modélisation mathématique des maladies infectieuses à l'Institut Pasteur à Paris. Il a fait sa carrière dès le début sur, au fond, la problématique de la transmission des pathogènes au cours des épidémies, formé comme biomathématicien, biostatisticien, et d'ailleurs, à l'issue de sa thèse en biostatistique, cherchait un endroit pour se former en stage postdoctoral. À l'époque, la Mecque était et est encore Imperial College à Londres, donc il est parti dans le laboratoire, dans l'unité de Neil Ferguson, qui était vraiment le pionnier avec Roy Anderson dans la modélisation mathématique, en particulier des étapes précoces des épidémies. Il s'est donc formé là plusieurs années en tant que postdoc puis de lecteur et au fond s'est bien entendu intéressé et a développé un travail de plus en plus fin sur au fond les déterminants de la dynamique précoce des épidémies qui bien entendu est un sujet tout à fait passionnant. Alors, le problème de la modélisation des épidémies, je pense que vous en entendez tous parler aujourd'hui, malheureusement bien souvent sur des plateaux de télévision. Certains considèrent que c'est un peu une boule de cristal et espèrent une espèce d'activité divinatoire pour deviner ce que va devenir l'épidémie. D'autres disent que ça ne sert à rien. En fait, la réalité est véritablement totalement différente et entre les deux. Ce qu'a fait au fil des années Simon, c'est véritablement de s'intéresser à ces paramètres initiaux, précoces du développement d'une épidémie, essayer bien entendu de mettre tout ça en équation avec la participation des mathématiques telles qu'il sait le faire, et bien entendu à réajuster au fur et à mesure de l'évolution les paramètres et les scénarios qui peuvent en être tirés jusqu'à affiner les choses au maximum. Ce qui marque le travail de Simon, c'est aussi de savoir sortir des simples mathématiques qui, effectivement, de temps en temps, mettent un doute sur la réalité biologique du phénomène et commencer à intégrer dans l'analyse de ces paramètres précoces qui vont permettre de définir ces scénarios évolutifs, des paramètres biologiques. Et je pense à terme, le défi, c'est aussi celui de mettre des paramètres, par exemple, anthropologiques et autres éléments qu'on voit émerger à l'heure actuelle au cours de l'épidémie de Covid. Alors, en 2010, on cherchait à la suite en particulier des problèmes qu'on avait eus avec l'épidémie de grippe H1N1 en France à muscler, si je puis dire, notre approche de modélisation des épidémies. On cherchait, en particulier Santé publique France et le réseau international des instituts Pasteur, une personnalité scientifique qui puisse aider à structurer cette spécialité un peu plus, et c'était vraiment nécessaire à cette époque dans ce domaine. Donc on a recruté Simon à cette époque en le LABEX de biologie intégrative des maladies infectieuses à l'Institut Pasteur, et depuis lors il a poursuivi sa carrière de façon extrêmement brillante avec des contributions dans plusieurs domaines, des maladies infectieuses émergentes bien entendu, et il a eu du pain sur la planche ces 10 dernières années entre les épisodes de grippe, Zika, les arboviroses et ainsi de suite, jusqu'à la pandémie que vous connaissez ces derniers mois de Covid-19. Très belle publication, déjà beaucoup de reconnaissances, bien entendu de financements nationaux et internationaux dans le domaine. Et puis, si je puis dire, la cerise sur le gâteau, c'est que certains d'entre vous savent probablement que Simon Cauchemez est le modélisateur dans le groupe scientifique qui entoure le président de la République pour prendre finalement les décisions que vous connaissez dans le suivi et l'évaluation et la mise en place des méthodes de prévention de la pandémie de Covid à laquelle nous faisons face actuellement. Donc je pense que pour toutes ces raisons, Simon méritait la reconnaissance de ce prix Lacassagne. Je suis là dans l'exercice physique extrêmement difficile. Simon de te féliciter, ça c'est très simple, mais de te remettre une médaille en distanciel, comme on dit aujourd'hui, c'est quelque chose d'un petit peu plus compliqué. Il faudrait au moins d'ailleurs que j'arrive à ouvrir la boîte. Donc voilà, je suis ravi, nous sommes ravis de te remettre pour l'année 2020 le prix Lacassagne du Collège de France. Tu auras cette médaille dès que possible, lorsque tu auras réussi à faire disparaître cette épidémie. Et nous aurons le plaisir de t'écouter, nous présenter ton travail dès maintenant.
Merci beaucoup, Philippe. Vous m'entendez bien? Je veux dire que oui. Donc, merci beaucoup. Je suis très honoré de recevoir ce prix, bien entendu, et très touché aussi pour les mots que vous avez dit. Donc, je m'excuse de ne pas être là dans la salle avec vous aujourd'hui. Et c'était un petit peu ce que j'avais planifié de faire. Et puis, un petit peu au dernier moment, j'ai décidé qu'il valait mieux rester en visio. Bien entendu, c'est en fait la raison pour laquelle j'ai préféré rester en visio, ça va être le sujet de cette présentation, donc sur le travail qu'on a fait tout au long de cette pandémie pour essayer de mieux caractériser son impact sur les populations en général et la population française en particulier. Je vais continuer en anglais, hein, sauf si, parce que je suppose qu'il y a peut-être aussi des anglophones dans l'assistance. So I'm going to switch to English now. And so, as you said, Philippe, there is always a lot of discussions about models and what they can contribute to in these epidemics. And so I think, this pandemic, more than any other epidemic, shows actually that we really need to have this kind of tools to support, to understand what's happening, to support policy making and planning. And maybe I think two key reasons why we need these tools is first to be in a position where we can really assess the threat posed by a virus like SARS-CoV-2, where it's really essential to be in a position when we can properly estimate like key parameters that describe transmissibility, severity, and the likely impact of interventions. And actually, that can be very difficult to do in a context where the data we have, if we have data, are often very incomplete, limited, subject to multiple biases, and sometimes contradictory with each other. And so models have a key role to play, and I think they have played that key role of trying to better integrate these different data types that we have access to and try to make a synthesis of this data. The second point really is, and I think that's for me is so central in any outbreak, is that all that matters really is the dynamics. The dynamical feature of these epidemics is really essential to our assessments. If you think about any epidemic, it's always going to start with a few cases, and what you should care about is not that right now we have few cases, but it's really what's going to happen in few weeks, few months if we don't do anything, because these epidemics have these complex nonlinear dynamics, characterized by that exponential growth. And so having models to properly capture, predict these dynamics is really essential for understanding what's going to happen and really to support policymaking and planning. So in this talk, I'm going to go back to some of the assessments that we have made and we are making in this pandemic since the lockdown. And really, my idea here was to show that it wasn't, static assessments. Actually, it was really about science in progress. So the assessments we make at a given time point are completely dependent we have on that time point. And so it's interesting looking back at how these assessments changed with time as we got access to new data. And of course, this crazy period has been a mix of both science and support to policymaking and planning, which has made it particularly challenging. So just very briefly about these models. So you have all sorts of models. a model structure that we rely a lot on to study the spread of diseases are compartmental models. And you have on the top of that slide, like the simplest version of these models, where you partition your population in few age group, in few compartments. So you have the compartment of susceptible individuals that can get infected at a rate that is going to depend on the contact rate between susceptible individuals and infectious individuals. And then when they are infected, they become infectious and can transmit. And after a certain time, they recover. And these models can be characterized with a set of ordinary differential equations. And they are relatively simple, but can already capture like the exponential growth you see early on in an epidemic, the fact that after a certain time, there's a depletion in susceptibles that can lead the epidemic to peak and then a decline. Of course, this is the simplest version of the model. And in practice for SARS-CoV-2, we use slightly more complex models that are going to use capture the more complex natural history of SARS-CoV-2, characterized by an incubation period, the fact that cases can be infectious before the start of their symptom onset, and that some of them are going to be hospitalized, potentially be moved to ICU, and eventually die. So you just imagine a few more boxes in that figure to capture this complexity. The other key feature that was clear almost from the start was that the gradient of severity, there's a huge gradient of severity with age that you can see there in one of the earliest estimates of that gradient. And so if you want to properly assess impact of that epidemic in the healthcare system, for example, it's very important to account for the age structure of the population. And so from the beginning, we use models that actually capture these dynamics of transmission between age groups. So using both the gradient of severity by age, but also data that describe how different age groups interact with each other. So we have a lot of like contact matrices that can describe these interactions. And so from the very beginning, we used that kind of model structure in our assessments of the epidemic. And this is, for example, an assessment that was made at the very early on, just after, like few days after the lockdown, when we were at that stage, and at the time we were wondering, what's going to happen in the coming weeks. And the key, we knew that the lockdown would have a huge impact on transmission, but how big would it be? To get a reproduction number of 1 or below 1, we needed to reduce the contact rates by 66%, which was huge. And even then, you could see like that in Ile-de-France, for example, the number of beds required in ICU would remain like very high. And so we use these models to try to have an idea of the capacity that might be required in ICU in different scenarios. And eventually we were fortunate that what happened was closer to the lower range of scenarios that we considered at the time. And even that, of course, was hugely challenging. And again, initially we didn't have any data from France, so we relied to assess these gradient of severity on data from China that we didn't completely trust. And so as soon as more data became available from France, we tried to properly characterize like key transmission and severity parameters from the French data. So on the left-hand side, you can see all the very detailed hospitalization data we had access to by territory, by sex, by age. So, hospitalization, ICU admission, death. And these data on hospital admissions are very important, but of course they are just a piece of the puzzle, because we know that they will describe the most severe cases, but we also know that a lot of infections are mild. And so at the beginning and for quite some time, we were wondering, looking at these data on severe cases, what exactly is the level of circulation and the proportion of the population that has been infected so far. And to make that connection between hospitalization and severe outcome on the one hand, and infections on the other hand, you really need data that can be used to make characterize that relationship. And at the time, so it was March, April, the best data we had, we think we had, was data from the Diamond Princess describing a large SARS-CoV-2 outbreak in a cruise ship where everybody was tested multiple times. They identified 700 cases, and out of those, there were about 14, 15 deaths. And so we could use this data to somewhat assess the proportion of infections that are going to lead to severe outcome, accounting for the age distribution of people in this cruise ship, and eventually use that to make a first assessment of the proportion of the French population that was infected up to the end of the lockdown. So these are the estimates that we obtain for the probability that you're hospitalized if you're infected. Obviously, all these parameters are hugely dependent on the age and often also on the sex of the individual. So we estimated that on average in France, if you're infected, you have about 3% probability of being hospitalized and 0.5% of dying. And then we could, with that framework, assess the impact of the lockdown on transmission. So as I said, it was even like the very big impact, some of the lowest scenarios that we considered early on, a reduction of the transmissibility of about 80%. And this first analysis suggested that about 5% of the population would be infected by the end of the lockdown, 12% in Ile-de-France, 11% in Grand Est. So of course, a lot of spatial heterogeneity, but with an average of nationally of 5%. So then, we were fully aware from the start that this cruise ship data was like very interesting, but far from perfect. And so we were very keen to try to have confirmation of these early estimates. And so we quickly looked back at all the data that was available internationally. And so we identified mortality data, age stratified mortality data for 45 countries, and they are the ones in yellow on the map. And some dots are all the places where we could identify the serological survey done in the country. Of course, we need these serological surveys to have an idea of the true level of circulation of the virus, and from that, be able to make an assessment of parameters such as infection fatality ratio. So we wanted to look at the big picture and try to see, after having looked at the French data, if we would get a similar picture looking at the international data. And the first striking observation you can see on that graph, so this is the risk ratio of death by age group. And if you look at these relative risks for those that are less than 70, you can see that in all the countries and all the continents, you have a very striking log linear relationship between the risk of death as a function of age. So there's first this very consistent pattern. Wherever you look at, you find that that very clear log linear relationship. Then the second observation is that if you look at older individuals, those more than 70, actually patterns are very different. In South America, in Asia, it looks like there are very few deaths in these age groups, potentially because of underreporting. And in Europe, there's also a lot of heterogeneity. So depending on the country you look at and what's happening in particular in nursing homes, you can have very different number of deaths in this group. So the take-home message we make from this figure is that if we want to use deaths to make an assessment of the level of circulation of the virus, it's likely we can rely quite well on what's happening in younger individuals, but then we shouldn't really it will be much harder to rely on what's happening in elderly people, because there's so much variability, potentially underreporting, or large outbreaks in nursing homes may completely change the picture. And so then, using this patterns of death by age group and the seroprevalence in the different countries, we could, for the first time, try to assess whether the different data we have for the different countries, the different seroprevalence studies, actually tell us the same picture about parameters such as infection fatality ratios. Of course, different countries may have different age structures, but with modeling we can like translate the results of a study in a reference country, and here we took the France as a reference country. So here you see the dots represent, like, looking at different sero surveys, what they say about infection fatality ratio, the probability of death if you're infected, in the French context. So for example, the sero survey in Slovenia would say that you have about you can expect an infection fatality ratio in France of about 0.25, and the one in England would say that actually the infection fatality ratio would be closer to 1.5%. So the first question we wanted to explore here are the different studies consistent with each other? And the clear answer from this slide is that no, even if you account for different sensitivities, specificities in this of the different assays that may certainly play a role, we find still a lot of heterogeneity that we cannot completely explain, and it's likely that different prevalences of comorbidities in the different countries may partly explain these heterogeneities. The other feature, of course, is that depending on so like this clear heterogeneity, if we take an average of across all these studies, we get an infection fatality ratio of about 0.7. The other quite obvious result is that depending on the population you're looking at and the age structure of the population, your infection fatality ratio can move from close to 0 in Kenya to close to 1% in Japan. So with these results, we were then able to develop a method to try to, from just looking at the number of deaths in those less than 70, make an assessment of the proportion in these populations that had been infected by SARS-CoV-2 for different countries. So this is again around the end of May or June time period, and just we get also from that study an estimate of 5% of the population infected in France, which at the time, in the context where there was no data, not any serological data from France, was something that was very reassuring for us. Then around that time, in June, July, we started to see a large epidemic rebound in French Guiana, and we supported like the authorities to ascertain the situation. And the first question was, given the huge difference in terms of age structure between metropolitan France and French Guiana, what could we expect in French Guiana? And if we just take our results from metropolitan France and apply them to French Guiana, accounting for this structure, we find that the probability of hospitalization given infection would be much lower, 3 times lower, meaning that for the same number of infections, we would expect 3 times less hospitalizations in French Guiana than in metropolitan France. That being said, if you have a lot of circulation, you still end up with important burden on healthcare, especially in a context where there was not a lot of beds in ICUs. And so after the national lockdown, the lockdown release, we saw a rebound of the epidemic, and then the authorities started to implement some very strict measures with curfews in the evenings, in weekends. Some localized lockdowns. And there's policymakers, when they're in these situations, have a very difficult situation, because for a few weeks, you don't know if your intervention is going to be effective enough, or whether you may have to increase capacity to develop more stricter measures. And so to support their assessments at the time of the curfew, we also showed them like some scenarios, like worst case scenarios about what they could expect if these interventions were not effective enough. So you can see that like different scenarios. And this is the baseline. This is the scenario with our point estimate that we had in our first study looking at metropolitan France. But again, because there were still a lot of uncertainties about these estimates, we also showed scenarios where we were looking at the lower bound of severity or the upper bound, and this was shown as a sensitivity analysis. So this was more to help them ascertain what might happen in terms of ICU bed capacity if interventions are not successful. And they also asked for assessment of short lockdowns, like 10 days or 15 days, which could actually have quite a substantial impact on the peak, but eventually that decision wasn't made. And like 10 days after, or a bit more after 15 days after the interventions were made, we could really detect a change in the transmission rates and revise our predictions accordingly. And then, like, again, to validate our model, that's in July, our colleagues from Claude Flamand from Institut Pasteur, Cayenne, did a seroprevalence study, and you see the result of the seroprevalence study. That's the black dot here. And we can use our models to predict what the seroprevalence should be, like if you trust the model, which was, and the prediction was very close to the one that we made in our baseline scenario, which for us, again, was another element to reassure us that our first assessments were relatively right. And so if you move that forward, we expect that about 30% of French Guiana has now been infected by SARS-CoV-2. More studies, seroprevalence studies have been are available now, in particular from Institut Public France, and you can see that the estimates they get for the end of seroprevalence at the end of the lockdown, around 5%, is very close to ours. A key question right now is, in that second phase, what's going to be the outcome of hospitalized patients, and here, looking back, of course, as the first phase is essential, and we assess like how the probability of being moved to ICU when you're hospitalized, the probability of death has changed over this first wave. You can really see like huge reductions of the order of 50% in these probabilities, with some variations by age group, which are likely driven by improvements in care, but also potentially that the mix of patients has changed. So we correct for the age structure of the population, but it's also possible that they nonetheless hospitalized patients that were milder, and so it remains to be seen in the coming time period, where in that spectrum of outcome we will be. And I just want to conclude on the current situation, where during the summer we've seen a surge in infections, initially in younger individuals, but then that quickly was translated into a rise of infections in older individuals, and eventually a rise in hospitalizations. And we are now in a situation where we see these important rises in hospital admissions and ICU admissions, very different than from the pre-lockdown period, where the number of hospitalizations was doubling every 3 days. Now it's doubling every 16 days, sorry. But with in some regions, it's doubling much faster, like every 8 days. So it remains concerning. Just to show you, to illustrate the difference between the early stage and where we are now. Clearly, at the time, there were many more infections, like just at the time of the lockdown, than what we have now, where we think we must be closer to 25 or a bit more now. And so again, when you look at these dynamics of hospital admissions, ICU admissions, coming back to what I said in the introductions, what we should care about in these situations is now not where we are now, but where we might be in a few weeks' time, a few months. And clearly, if we stay on these trajectories, that will be a very difficult situation for the healthcare system. Now, maybe a reconforting thought is that if you look at the effort that we have achieved when we compare where we are now to where we were in pre-lockdown, the effort is really huge, because we managed to reduce the transmission rate by 50%, which is a very important effort. And what we would need to be able to control this epidemic is to do a bit more, like to reduce it by an additional 15%. So 15% compared to these 50% reductions is not enormous. And like, even if we were didn't go as high as 50% additional reductions, but just 5 or 10%, that could already make a huge difference in terms of outcome for the healthcare system. So we need to make that extra effort to avoid the very difficult situations in the healthcare system. Okay, I'd like to stop now. Thank you again for the prize and for the attention, and also thank all the people that have contributed to that work at Institut Pasteur and in a lot of other agencies that we've been working with. Thank you very much.